Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County. It's June the 12th, and this is the next of our Facebook Live events where you get to ask questions. Just put them in the chat section of the Facebook Live, and we'll try and answer them. As you know, on almost all of these things, I sport the newest gear that you can use for protecting others if you happen to be asymptomatic or pre-symptomatic with COVID. And while we've used the balaclava, and that's typically what I use each day, people sometimes feel like they can't wear those cloth coverings and wonder if there's an alternative, and this is an approved alternative. So this is a face shield. It covers my face, it covers the sides of my face, and is lower than my chin, so it works well. This actually is a face shield that I got at Oregon Tool and Supply, and that I use this kind of face shield when I work in the shop, especially when I'm doing a lathe, because I'm not that good at it and things sputter up in my face. And this provides good protection. It allows me to use my glasses and see. And for people who lip read, you can also lip read through this. So these actually are pretty nice. And if you're claustrophobic, they're not bad at all. For people who don't like that mask on the face, you don't have to worry about it. It does not fog up your glasses, which is a big deal. And actually, in the long run, it's probably cheapest. This is only about $20 and presumably could be reused indefinitely, whereas the balaclavas are about $10 a piece, and you need to have a bunch to review. So for people not wanting to use a mask, these are perfectly acceptable and acceptable by Oregon rules if people want to use it. I'm going to take it off now a little bit so that you can see it also flips up if you want to do it. But it's really quite comfortable to wear, and for people who want to use something but don't want to use a mask, this is a good alternative. So again, it's June the 12th. Let's go through what's happening with COVID. Still a very, very active pandemic, about 7.6 million cases in the world, about 100,000 new cases a day every day, and 425,000 deaths. That's a lot of deaths. 425,000 is approaching losses in some of the major wars that we've had. And Brazil, Russia, and India continue to be the areas where it's really spreading fast. Brazil has had some political issues where they're not releasing full numbers, so the numbers that we see are probably an underestimate of what goes on. And even as an underestimate, it's shocking with 30,000 new cases a day. Russia, India, and Iraq are also starting to have some really big outbreaks, and so that's a real worry. Every continent except Antarctica has cases, and so we're seeing it spread well through the world. But there's some good news. The good news is that both Australia and New Zealand really have gotten this under control. Iceland has also gotten this pretty much under control. And actually, New Zealand says they have no active cases right now, so that's pretty amazing. So it can be done. It's obviously easier if you live on an isolated island, but it can be done. In the U.S., we're at 2.1 million cases, and we're still stubbornly at about 20,000 cases a day. We had thought that we'd hit 30, would come down to 20, and then rapidly come down to 10, and then 5, and then 2, and then go away. But we're kind of stuck at 23,000 cases a day, and now we're at 116,000 deaths. And I heard Michael Osterholm, who's one of the gurus on this, suggest that we may well hit 200,000 deaths by September, and that's before the flu season and before we expect this to come back. Big outbreaks in the U.S. in California, Texas, Florida, North Carolina, Arizona, Oklahoma, and unfortunately Oregon. So for the last few weeks, I've been giving you this glowing word about Oregon and how well we're doing, but I can't give you that today. So, we in Oregon tried to flatten the curve, and if you looked 2 weeks ago, or 2.5 weeks ago, we had an exactly flattened curve. You couldn't have drawn it any better. It went up, it wasn't very flat, it came down about as fast as it went up, and it looked like we would get to the point where we would have very few cases. But then you remember on the 15th, we opened up, and it's not just opening up, but it's the idea of opening up that encourages people to do less social distancing. So there's amazing ways that they're tracking social distancing. So every time I drive in the car with my phone, they know how fast and how far the person who has this phone is going. Now, they say it can't be linked back to me, but I'm not sure about that. But they know basically how fast you're going. So like when you're on the freeway and you're using, and you look for the traffic apps, the way they know that is that they don't have people there calling in about what the traffic is like. They see how fast and how slow cell phones are moving. And when the cell phones start moving more slowly, it shows that there's congestion ahead. And it's remarkably, use Google Maps, it's remarkably accurate. Within like a quarter of a mile, you can see where the slowdown is. And so using that kind of technology and looking to see how much people move, we know that starting in about May 15th, Oregonians started moving a lot more, traveling more, going to work more, doing less telecommuting, which is kind of what we expected. And you remember when we talked in May, we said when we opened up, we'd start to see a surge in cases. Well, we've seen that surge in cases. So over the last week, we've had cases one day with 114, one day with 142, one day with 178 cases. This is far more. For months, weeks at least, we were stuck between 20 and 80, and now we've had this big surge of cases. And what does that do to? Well, some of it is due to more testing. So we're clearly doing more testing, and we're doing more asymptomatic testing. But the increase in amount of testing we're doing does not account for the increase in cases, maybe 10 or 20% of it. The second is we've had a few big outbreaks, and there's no doubt that these big outbreaks have really contributed. So Pacific Seafoods, the Oregon State Penitentiary, Townsend Farms, Harry and David, a bunch of these places have had outbreaks that have really contributed to the numbers. But those places existed back in April and May, and they didn't have the big outbreaks then. So some of this is real. And when you look at where the cases come from, they come from so many different places around the state, suggesting that this is not it. So I think we have to suggest that in Oregon as a whole, that we're truly seeing the second wave. So I graph these things out every day like the nerd I am. And you could see this nice peak, and it looked like the wave may go away, but we saw as the peak, and now we've seen a second peak, which actually is a little steeper than the first. So the second wave is there. Now it turns out that the number of hospitalizations has increased, but not that much. The number of deaths is kind of steady at a few a day. So I don't think we're in a dire situation, but this increase in cases is pretty concerning, because a lot of times the increase in cases maybe at a food plant or a school or something, but then what happens is a week or two later, grandma gets it, or somebody in the nursing home gets it, then you start to see it. So I think this is a bit of a worrisome time, and I think we have to pay attention. Now the good news, Douglas County, no new cases again today. And again, we're kind of stuck at 29 cases. We've had no serious cases in the last few weeks. Of the 29, 27 have recovered. We continue to do more and more testing every day. We're over 700 tests that we've done through public health, over 3,300 tests that we've done throughout the community. So we've done a lot of testing. We're now, about 3% of the population has been tested, and we're just not finding new cases, which is great, suggesting that the disease is not really widespread here in Douglas County. But it's not very far to Lincoln County. It's not very far to Harry and David. And so these things could clearly get spread. And because we do have people who come and go to Diamond Lake or go hiking or go to the coast, we are worried that we're going to start to see more cases. We're still doing testing. We did a big clinic today, 20 some odd today. We're going to do it again tomorrow in Reedsport, and then we'll be here next Tuesday and Friday here in Roseburg, and I think next Saturday in Reedsport. So we're really... we're really testing. We're just not finding it here. And that shows, I think, that it's not here now. But when I see, cases in Medford, case in Lane County, case in Lincoln County, I know those places aren't far away, and we might still see something here. So that's where we are on the case count and what's going on. We're in phase 2, so we're allowed a little bit more leeway. The governor today suggested that we should put a little halt on this until we see what's happening. So Multnomah County was going to open up. A couple of other counties were going to phase 2. And I think this caution, this pause for a week is exactly the right thing to do. I think to move forward with more reopening, not knowing we're going to see in the next week, would be foolish. So again, the governor talks about her walking out onto the ice, and this is that sound of cracking. So if you've ever lived in a place with a lot of ice, you can put up with a little bit of cracking, but you always stop for a second and look to see, did that crack spread or whatever, and then you very gingerly move to the next step. Doesn't always work. I actually fell in one time doing that, and it was really cold. So Misty says, I hear the virus is becoming less potent as it spreads. Is there any evidence of that? And I looked that up today. There's one guy from Italy that has suggested this, and then there's a group from New Mexico that suggests that it's getting more potent. If it was getting less potent, what you'd see is more cases and a lower death rate. But when you look throughout the world, the death rate or the death percentage remains stubbornly above 5%. So if it's becoming less potent, I don't know where it's becoming less potent. I think what's happening is we are now, because we have more testing, finding more asymptomatic people or minimally symptomatic people, and they're less likely to die. Whereas I think early on, we were finding a lot of cases in nursing homes where people were much sicker. So it could be. I mean, these viruses do change, and sometimes viruses do peter out. But usually what happens, sadly, is if there's a variant of the virus, the more potent kind of the virus now takes over. So that's what we see with flu. So flu does change through the years, through the year actually. So they make the flu vaccine in February of the year for the next winter. So you have to kind of guess what flu is going to be around. And usually the guess is pretty good, but sometimes it's not good. And the reason it's usually not good is that the virus that they plan for in February has changed a bit. And it's typically a more potent virus that it's changed to there. Now, occasionally, they think it's going to be a strain that circulates and you don't ever see it. Maybe they got less potent. So I think it could happen either way. But I don't think there's any convincing evidence that the virus is getting less potent, although the tape has gotten less strong. So could there be a third wave in the fall? I think it could be. So I think what I'm concerned about is that we've seen the initial wave. We're going to see another, I think, little wave now. And then I think we could see another wave in the fall, because in the fall, we are planning for more gathering events, right? So in the fall, higher education may reopen. Schools will almost certainly reopen. Businesses will try to reopen. We'll all want to go to a Ducks game. All of those things will happen that will increase mixing. And just diseases do seem to get stronger in the fall. So as a pediatrician, about half of what we deal with is infectious disease. And so in the summertime, it's like, there's not much coming in today. You go a whole day without anybody who's sick. And then starting in September and October, it starts to go up. By November, it gets miserable. And November, January, and February, November, December, January, and February are just miserable being a pediatrician because everybody seems like they're sick. And then starting around Easter, it starts to get better again. So I really do worry that we're going to see a third wave in the fall, just because diseases do tend to get worse in the fall, and because we're planning on doing more mixing. Yeah, so Scott says, are we getting a lower death rate versus hospitalizations with more experience we have at treating this? Not appreciably. So I wish I could say, we were having 20,000 cases a day in the U.S., but we're down to 100 deaths. We're not seeing that. We're still getting about 1,000 deaths a day and about 20,000 cases. So still about a 5% mortality rate. So I wish I could say I would see that. The things that are out there to treat this are not that great. There's the standard using a ventilator and whatever else. Remdesivir does seem to help a little bit, but just a few percent. There are some of these anti-cytokine agents that people are talking about, probably just a few percent. Pepsid is out there, maybe helps a little bit. There's convalescent plasma, which we'll talk about later, not helping that much. So, but we are getting a little bit better at treating this. I think what people are recognizing is that, for example, prone positioning, an incredibly seemingly simplistic thing of, instead of having patients lay on their back, to have them lean up, does seem to help, and I think we're doing better with that. So I think we may be getting a little bit better at it, but nowhere near as good at it as we should be. So Lisa says she has a fear about norovirus circulating. I heard there's a concern that this may go around now since we've been sheltering ourselves from common bugs too long. Well, the sheltering from common bugs is not going to change for norovirus, because you do not make very good immunity to norovirus. And that's why people who work on ships can get norovirus every year or several times a year. So that wouldn't do it. Could norovirus go around? Absolutely. Norovirus is the cruise ship kind of vomiting diarrhea virus. Actually, we have seen an incredible decrease in the number of norovirus cases in Oregon. So norovirus outbreaks are reportable in Oregon, so you get to see them. And norovirus outbreaks have gone way down, because it usually happens when people gather on a cruise ship, at a picnic or sometime like that. So the cases have gone down. Will norovirus come back? Undoubtedly, once we start recirculating. So do you think COVID-19 could have been around in 2018, Zach asked? It certainly could be.
although the antibody tests, which are pretty darn good, are looking for this in older specimens. So they look for, so the way they test this actually is on the really high quality tests, is they check specimens from 2017 and 2018 to see if there's any COVID antibodies. There should not be if COVID did not exist. The ones that have been positive when they get retested by a better test aren't there. So there's no evidence that this was around before maybe the earliest fall of 2019. Yeah, I can't find any data to suggest that it was there before. Now, was there a lot of other bad crud around? Absolutely. We saw a lot of sick kids in November and December of this year with colds and flus and pneumonias. We never exactly figured out what it was, but when we have checked them now for COVID antibodies, they don't have them. So we don't think it was COVID, but it was something bad. So Debbie says, is there anywhere we can get a test back within 48 hours for travel? And the answer is yes. We'll put this on the chat. Nova Healthcare is using an antibody test called a Sophia Kidal test, and they can get you the results of that relatively quickly, and that will count for travel. So I will put that on the site on how to get that. I say this with a bit of a pause. So Alaska has done a really good job in keeping down cases, because what they've done for people is when you get to Alaska, you need to quarantine for 2 weeks and then you can go and do what you need to do. Alaska and Hawaii have done that, and they have done a great job with keeping rates down. New Zealand and Iceland did that. They've done a great job with keeping things down. However, now, it's fishing season in Alaska and people want to fish, and people don't want to wait around 2 weeks before they can fish. So they've come up with a scheme that if you get a test before you get there, you can not do quarantine. I think that's badly, epidemiologically, that gives me some pause. Because if you get tested tomorrow, there is a chance that test will be positive because you had an asymptomatic infection 2-3 weeks ago. You don't need to not go, because if you were infected 2 or 3 weeks ago and simply have a positive antigen test today, you're no longer contagious and you should be able to go. But since you didn't have the test 2 or 3 weeks ago to show it, they're going to make you not go to Alaska or to wait 10 days before you can enter. So it's going to unfortunately, on the one hand, deny people who should otherwise be able to go to Alaska. It will find some people who are asymptomatically positive and are contagious, but unfortunately, in the whole group of things, it's only 30% of the people who are at risk will test positive. There's a whole bunch of people who will go to Nova, get the negative test on the way home, pick it up from somebody, and then be very contagious when you're in Alaska. They'll show their negative result at Alaska, get in, and spread it to people in Alaska. Or during their travel to Alaska, the guy on the plane next to you will cough on you, will give it to you, and then you'll get it while you're in Alaska and give it to the people in Alaska. So I worry about this strategy, because when I did the math, it looks like of 100 people who were infected, or of 100 people, assuming that there were some that were infected, that 12% would be unnecessarily restricted, 28% would be caught, and 60% of the people who would be contagious during their trip would be missed. So it's a risky thing. Anyway, getting back to the question, where can you get the test? You can get it at Nova. They'll do it. It's called a Sophia Kidal test, SOFIAQUIDEL, and they'll be able to do it. Call beforehand to be sure they have it, because there must be a lot of fishermen in Roseburg, but there's been a big run on these tests, so check with them beforehand to be sure that they have it. Okay, so Heidi says, my mom misses her family and wants to see them. So she's 65 with diabetes and cardiomyopathy. Is it okay to visit her? And so again, this is so legally it's fine. There's no issues with gatherings of up to 10 family members. There's no issues with that. So this is not a state requirement or anything else. This is a risk analysis. So at 65 with diabetes and cardiomyopathy, you are at moderate risk, maybe there's no calculator, but somewhere like 5 or 6% chance of dying should you get the disease. Now, again, there's very little disease in Douglas County. So it's the risk of getting the disease and the risk of dying if you get the disease. So the risk of getting the disease right now is pretty low because there's not very much disease around in the community. When we screen and screen and screen, we haven't found a positive case in a long time. So, we go to Reedsport every weekend and screen people every weekend. We have yet to find a positive test in all those screenings. We did a couple hundred over the last few weeks and haven't found any. Mercy has done 700 consecutive ones at Mercy, hasn't found one. So the amount of disease in the community as of last week is really quite low. So should she see them? Well, a lot of it depends upon what kind of exposure you're going to have. If you said we're going to see them, we're going to go to the beach and we're going to sit 10 feet apart on lawn chairs, I think the risk is pretty low. If you say, oh, they're coming from Arizona, we're having a huge outbreak right now, they're coming from Arizona, they're going to fly on a plane, and then we're all going to sit together at the dinner table, that's higher risk. And you need to judge your own risk tolerance for what goes on. So, to give you an example, my mom's risk tolerance is like 0. She's not wanting to go out to do anything. And then other people you see, I was at the gym today and there's this little old lady who's probably in her 80s and she's just around seeing other people not wearing a mask. So very different risk tolerance and you have to do it. So this is a moderate risk activity, not super high risk. The joy of seeing your family is huge. And I weigh this every day because I'm 64 and I have 2 grandkids and I want to see them. So, question asks, are most deaths because of a compromised immune system? Are the reports of deaths from other conditions diminishing? We don't think so. We think that the underlying conditions and age is pretty similar. We've had some cases of younger people without other underlying conditions dying. But again, this is mostly older people with underlying conditions. And those underlying conditions are a lot of things. They're hypertension, obesity, COPD, neurologic disease like Alzheimer's. So I think that's happening. So we don't think that the deaths in that way are changing very much. Now, overall, the death rate is slowly coming down as we find more mildly symptomatic people, but it's not going down remarkably. So, I will really be happy when the number of cases can continue steady, but the number of hospitalizations and deaths really go away. We haven't seen that yet. So Carrie at Nova says they're doing that test, but some aren't accepting them. Yeah, so this is a complicated story because when you look at the Florida rules or the Alaska rules, it says they will accept a molecular test. We think this is a molecular test. We do not know how Alaska is. We don't know how Alaska is accepting this test. I think the test is a perfectly acceptable test. When you look at the false positives and false negatives, it's similar to like the Abbott ID, which they would accept. So I think they should, but I don't have much sway in Alaska. So you may want to check them before. And if somebody can find the detailed ruling, we just found what was printed on the website. If somebody can find the detailed ruling, send it to us or send us the link, and then we'll evaluate whether a Sophia test should be acceptable. Yeah, so Misty says, I've heard that COVID may be a vascular disease versus a respiratory. Then how does that change the treatment and precautions for the disease? So I think the evolving theory, and again, it's evolving, so it may change the next time I come see you, but the evolving theory is that COVID starts as a respiratory disease. For young, healthy people, it can be so mild that they may have no symptoms. For otherwise young, healthy people, they may have a little cough and fever, but nothing more than a little bronchitis. But then as you get sicker and older and have more underlying conditions, it's more likely to spread from a respiratory disease to a vascular disease, meaning that not only is it in your lungs, and it's clearly in your lungs because you have all these abnormal CT scans, but it now starts to get into your blood vessels, and it gets into your blood vessels. It causes your body to really respond. So, your blood vessels have this lining called the endothelium, and this endothelium is incredibly active. And this really active endothelium helps to stop clots, right? Maybe if we didn't have that, every time you got a cut, you would die. So it helps to stop clots, and it helps with inflammation, because in the old days, when you got an infection, you get blood poisoning, and blood poisoning would be infection going through your bloodstream. So the lining of your blood vessels is keyed up to respond to inflammation and to respond to clotting. And what we see happens in this disease, so it almost always starts out pulmonary or GI, but then when it gets into the endothelium, your body makes what is called a cytokine storm, where your body kind of really tremendously overreacts, and it clots in places that it shouldn't, and it causes changes in the vessels at places it shouldn't. And so, yeah, it is looking now that it's starting as a pulmonary disease and then moving on to a vascular disease. And it seems that when it moves on to the vascular disease, that's when it starts to get really serious. So Lisa says, I'm 65 and been isolating. I'd like to see family in Portland who I don't think are using protection measures. Should I see them? Well, again, legally it would be okay. There's some risk there, right? If these people are not isolating and they're running around and going to school and doing those kind of things, going to bars and whatever else, and there is some risk. Now, you could mitigate the risk by meeting them outdoors. And outdoor meetings are pretty darn good. We had a wonderful student who I've worked with who is going to go to medical school. And we wanted desperately to celebrate her acceptance to medical school. And typically what we would do is we'd have a luncheon in the break room, and everybody would bring a potluck, and we'd all gather around and chat for an hour. And we decided that was too risky to do, so we did it outdoors. We had a little outdoor party, and it was kind of silly, but it was actually, for me, really touching that we were able to do it and see people. So there's other ways to do it. So you could go ahead and limit protection. You could use a face shield. You could use a mask. You could limit the measures. And there's all kinds of different creative ways to do it to reduce the risk. So I've told this story before, but I'll tell it again for the people who weren't there before. So I have a dear friend who is my age, a little older, and they desperately want to see their grandkids who are in New York. And the grandkids are kind of still isolated, living just at house. And the people here in Roseburg are here at their home, and they're desperately missing each other. And because the people here in Roseburg are a bit older, they're at higher risk. There's some underlying conditions. And so the question is, how could you do this safely? So we kind of schemed up this plan that if they quarantined in New York for 7 days and then took 7 days to drive across the country and really limit their exposures as they drove across the country and then stayed here at their beautiful home in Roseburg, they could do this with really, really, really minimal risk to all. Because even if these people got exposed today, if they quarantined at home for a week and then took a week to drive over here, they would no longer be contagious. And then this family could spend the rest of the summer together, enjoying and relaxing. And it might be, for everyone, maybe the best summer of their lives, where they could have this summer where there'd be no other pressures. When we travel sometimes, it's like, we're getting up today, we're going this place. We're getting up tomorrow and going to this place. Imagine if you just really had a staycation where you could stay and enjoy the beautiful weather and the other kind of joys of Roseburg. You could do that. So I think you should do it. I think you should look at the risk, you should evaluate the risk, and you should do it in the safest way possible. And again, what's the safest way possible? Well, if people certainly don't do it if they're having any signs of illness, to distance as much as you can, to do it outdoors is so much better than indoors. And maybe to wear a mask or a face shield, that's a little hard at a family gathering, but those are the things you can do to reduce the risk. Okay, so Donna says, is it possible to purposely expose yourself so there's minimal exposure, upping your chances of having a mild case and developing antibodies? And so this is a strategy, right? So in the years past, before we had good vaccines for something like the mumps, you used to have these things called mumps parties. And the reason you had mumps parties was that if you got mumps as a kid, it generally was pretty mild and you were likely to get it at some point. But if you got it after puberty, you could get swelling of your testicles, which was really painful, they say. And so then people tried to get mumps before they were in puberty, so you'd have these mumps parties. So in that case, it made some sense to do that. It certainly makes much more sense to get a mumps vaccine. For this, here is the problem. The problem is that there are almost no deaths from mumps. There are some deaths from this, even in people who are otherwise young and healthy. So there was some actor I saw the other day who's just struggled terribly with this, lost a leg and then died. I mean, this was somebody with no underlying conditions, who's otherwise well. So if you expose yourself and somehow got a severe case, and we don't think there's any way to give yourself a mild case, we think you're going to get it. We don't know if you're going to be serious or mild. I mean, chances are if you're young, you'll be mild, but it's not guaranteed. But could you imagine if you got it and then got sick like that and died? You think that was pretty silly. The other deal with mumps is that mumps gave you long-lasting protection. So once you had it once, you're very unlikely to get it in the future. We don't know about that for COVID. So wouldn't it be miserable to go ahead and get it, get a severe case, find out the antibodies didn't work, and then 6 months get another severe case? Yikes, that would be terrible. So I don't think it's a good strategy. I know there are people wanting to do it, and I fancifully suggested one time that would work, but I don't think so. So Loretta asks, does bicuspid aortic valve, coarctation of the aorta, aortic stenosis, and atrial fib make me at high risk? Yeah, sorry. It does. So bicuspid. So usually the aortic valve has 3 leaflets. And these 3 leaflets are like upside down parachutes that open up to let the blood go through, and then they fill again as they come down. And with the bicuspid aortic valve, you only have 2 leaflets. And so those leaflets have to work 1.5 times as hard, and they frequently have troubles. Coarctation of the aorta is a narrowing of the aorta. Aortic stenosis is a narrowing of the aortic valve. So you've got a lot of turbulent flow in there and likely a lot of endothelial disease. Atrial fibrillation is a rhythm disorder which puts you at risk for lots of things, but I have not seen that it's specifically related to COVID. 70 is being at high risk. So you would certainly be, by every category, somebody in the high risk thing. So what does that mean for somebody who's high risk? Well, it means stay home as much as you can. Go out when you need to, and when you need to, wear a face covering, maintain social distancing, and that would be the best suggestion. Okay, a couple of other things. We cannot go a day without talking about masks and the confusing story about masks. Should we, shouldn't we, should we, shouldn't we? And again, a study came out in Lancet suggesting that masks really do help to reduce transmission, especially if both people wear it. And that goes along with what we've said. The WHO has been very confusing. They said, wear it, don't wear it, wear it, don't wear it. Their last is, if you have access to a mask, wear it. So if you have access to a mask, wear it. Other things that have come out, another question? So other things that have come out in the last little bit is about reopening schools. So I have sort of a little inside track on what's happening with reopening schools. The goal is to reopen elementary schools in the fall and to reopen colleges with some changes in the fall. These are going to be stressful times because in schools they want kids to maintain social distancing, so they want to have a lot less kids in the class. We don't know how that's going to work because most of the classrooms are quite big. Most of the class sizes are big and the classrooms are only as big as they are. So many classrooms will only be able to have 10 or 12 kids in the class. We don't know how this is going to work. The other part is the social distancing on a bus is going to be very difficult. You'll either have to have kids get to school on their own, or other people drive them, or multiple bus routes, so we're not sure how that's going to work. And some of the things we enjoy most about school, recess, lunch, gym class, are all going to be markedly different, we think, in the fall. For sports, kids are likely to go back to sports, but they need to maintain social distancing, and contact sports are still out. I think we've decided that volleyball and soccer are not really contact sports, so that they're going to be allowed, but that football probably is a real contact sport, and wrestling is a real contact sport, and we're likely not to get back to those. For colleges that re-enter, they're going to do all kinds of things with testing and whatever, but we're not sure how that's going to go. I worry a little bit about elementary schools, but I think with elementary schools, there's going to be one teacher who's going to be telling kids what to do. Their parents will take good care of them when they get home. And you can pretty much have the same 10 or 12 kids in the elementary school class at the same time. So if there would be an outbreak, it wouldn't be hard to do. In addition, kids don't seem to get very sick, but they don't seem to get it as much either. So a study came out today from Vo, Italy. And Vo, Italy was the place where there was the first death in Italy. It's a little to the side of where Bergamo is, where it's outside of Venice. And so they, early on in the disease, they studied almost everybody in this small town of 3,000, and then 2 weeks later they did it again. And what they found was that the highest rate of disease was in people in their 40s, 50s, and 60s and 70s, as well as the highest rate of death for people who had the disease was in that group. In kids, they tested about 300 kids. Not a single one tested positive. So we're not exactly sure. Not only kids not get very sick, but they don't seem to even get it that much. So we do not know what's going on there. So the Vo Italy story, if you can find it, is really a fascinating story. So some people say they get dizzy and lightheaded after wearing a mask for a while. Why? And we think that is because some people do tend to hyperventilate when they wear a mask. And when you hyperventilate, you get dizzy, lightheaded, and your hands start to tingle. And that's just a normal reaction to hyperventilation. So you can try to see if it is hyperventilation. Take 30 deep breaths over a minute. And if you feel like, oh, I'm feeling a little dizzy, lightheaded, and my fingers are tingling, and then you say, that's just what I wear with a mask, it's because hyperventilation. Now, hyperventilation is not dangerous, but it's super scary. And so I wouldn't recommend that if you get that when you wear a mask, that you wear a mask. I would recommend you see my friend Milo at Oregon Tool and Supply and get a fashionable helmet. They come in all colors, and so that you can get them about $20. And so if you want to protect yourself and don't want to wear a mask, this is a great option. Other studies that we've seen over the last week is about what's going to happen in the fall. Is going to be a second or third wave. We do not know. We really, really don't know what's going to happen in this third wave. I mean, it really could go away. It could be nothing. I think the consensus opinion, though, is we have to be really concerned about what's going to happen in the fall in September, October, and November. Okay, that's all the things I had today. We'll give one last chance for a question if people have questions, and then we'll do it. A couple of other things, we'll just have to come in and do it. One is the WHO had a big kerfuffle this week when somebody talked about asymptomatic transmission. And this is one of the things that happens when you get asked questions at a press conference, and I fortunately have only done a few of those, where you ask the question and you answer the exact question, but you don't put it in bigger context. So the question was, is there a lot of asymptomatic spread? And she said, no, actually in the literature it's quite rare. Well, I think what she got a chance to do it again, and she did. You should say, well, let me clarify. We think that we clearly know there are a lot of people that are asymptomatic, 20, maybe 40% of people. Some people would suggest even more, but there are a lot of asymptomatic people. We do know that people who are pre-symptomatic, that is, people who will develop the symptoms in the next day or two, are very contagious. And there's great stories in the literature that those pre-symptomatic people cause a lot of the spread. And almost all of the super spreader events have been in people who are pre-symptomatic. So that's it. Now, there are people who are asymptomatic and remain asymptomatic. So, the only way you know them is you test them when they're asymptomatic, and then you follow to see if a lot of people in their family got sick. There are very few reports in the literature of people who've gotten tested, were asymptomatic positive, and then had a cluster tied to them. There's one that I know of. But it doesn't seem to be very common, and that's why she said it's very rare. Now, the problem is we don't know about a lot of these asymptomatic people, and we don't track a lot of these asymptomatic people. So it's possible that when we have a case and we didn't know where it came from an asymptomatic person. But that's incredibly hard to tell. So she kind of got herself in a bit of hot water by giving a short answer rather than the long answer. The other thing that came out is, remember this aircraft carrier, the Teddy Roosevelt, we've talked about it a few times. Aircraft carrier is one of the most amazing things in the world. So if you ever want to see something that's really amazing, the Midway down in San Diego is a recently retired aircraft carrier that has all the planes on it still. It still has a lot of the stuff in it. And it is one of the most amazing things. I think maybe my favorite museum on the West Coast. Anyway, it's so crowded, so much stuff on there. And, amazing that here is a city of 5,000 that has 2 nuclear reactors downstairs to power it, has an airport on the top, a hospital in the middle, and by the way, nuclear weapons. But other than that, and it's mostly run by 20-year-olds. So, having been in the Navy for a long time, there are officers and senior non-commissioned people in their 30s, 40s, and 50s, but there's rarely anybody above the age of 50, except maybe a doc or two. But there's rarely anybody that old. These are mostly relatively young people running this, and pretty much the day-to-day operations are 20-year-olds. So anyway, they had this big outbreak, and it was mostly 20-year-olds who got it. The 20-year-olds were about 80% were symptomatic, mildly so. One guy died. 20% or so were asymptomatic and remained asymptomatic. They were unable to tell if there was asymptomatic spread. What they did find was social distancing. The people who said, I generally stayed away from people, I generally wore a mask, I generally wore eye protection, had lower rates of infection than people who said, didn't care about that stuff. So it showed that those things worked. It did show that about 20% of the people were asymptomatic, and it showed that it can spread very fast in a confined environment. The other thing was about convalescent plasma. So this is something that goes back 100 years. And so the story is that once you've had a disease, your body can make antibodies. Those antibodies typically prevent you from getting the disease again. It's really an amazing system. So it's sort of like your body has this invader. Your body has these B cells that figure out, I wonder what would block that. And over the space of about 48 hours, it finds exactly the right thing to block that disease. Now that is pretty darn amazing. I mean, how does it do that? How can it look at this protein or look at this invading virus and figure out, boy, this exact protein would go ahead and do it, but it does it. And so in the space of a few days, it figures out what the antibody is. Over the next 2 weeks, starts to produce a tremendous amount of IgM antibodies and then IgG antibodies. The IgM antibodies stick around for a few months to help fight the infection. When the infection's gone, the IgM antibodies go away, but the IgG antibodies stay. And the B cells that made those IgGs stick around for years and years and years. They divide and whatever, but they stick around remembering. So if they see that protein again, they can go ahead and make a big flush of antibodies to help protect it. So antibodies are one of the key things your body uses to protect against infection. And that's why much of the research, and actually Bob Dannenhoffer thinks, the key to fixing this is going to be through antibodies. So it could be the only antibodies that you make will go ahead and protect you in the future. I think that's iffy. I think the second thing that could happen is that you could use convalescent plasma. So convalescent plasma means you take somebody who's had the disease, they got a lot of these antibodies, and then you give that convalescent plasma and it should work. A couple of studies showing that it's really quite safe. A little bit of an inkling that showed it was effective, but the biggest study that came out from China that showed that there was no benefit. So that was really disappointing that convalescent plasma in the Chinese study didn't seem to help. There are still other studies from Italy, the UK, and the US that are coming, but I was hoping to see that, that was going to be great. However, there is a study about something called IVIG. So IVIG, convalescent plasma is all the plasma that comes out, and the antibodies make up a tiny little fraction. But what you can do is you can take a bunch of plasma from a bunch of people, purify out the immunoglobulin, so immunoglobulin is Ig, and then put it in IV form, which is called IVIG. And IVIG works for lots of different diseases. So for example, this Kawasaki syndrome, IVIG works good, works well. I think for multiple sclerosis it works, and for other diseases it works. So there are a couple of studies checking out IVIG for people who have this, and it looks somewhat promising. Now, again, typically these promising studies are on 9 people they tried it on, and it seemed to work. What you really want to do is try it on 500 people, and then do 500 people where you don't give them the treatment and see if there's a difference. Because a lot of these things look promising early on, but when you compare it, it doesn't show a big difference. But IVIG maybe works. The other one that might work would be a hyperimmune globulin. So hyperimmune globulin is something that they used to use a lot. So to get a disease, they would typically do it in horses. So they'd give a horse a toxin. The horse would make a lot of antibodies, you'd purify those antibodies and you'd give somebody the horse serum. So you may have heard about that in the old movies. I'm getting a shot of horse serum. And that was serum that was raised against the toxin, and that worked well. We don't do it with horses anymore. We use human plasma donors to get it. So hyperimmune works. And we know it works well for many diseases. So for hepatitis B, if you're not immune to hepatitis B and you happen to get stuck with a needle with hepatitis B, if we give you a shot of hepatitis B immune globulin, it'll pretty much protect you from getting the disease. So imagine now if you could raise some COVID hyperimmune globulin. Would that work? It might, and so they're working on that. And then the other way to do it is to find the antibody that works and then just grow that antibody rather than in a lab. So you would do this and then you would get something called a monoclonal antibody. And so there's some monoclonal antibodies out there for diseases and for other kinds of things. So we know how to do it and it could work. And then monoclonal antibodies could be used either to prevent the disease. So like I was exposed, so give me a shot of this so I won't get it. Or in the early stages of the disease, if you get it, it seems to help your body fight the infection. So how is this going to end? Well, either it's going to burn through the population, everybody's going to get it, and people will develop immunity, but that will require that a lot of people get sick and that the immunity that we get lasts. We could get a vaccine, and the good news is that there are a bunch of vaccines now in phase 3 trials. So that'll be great. We could get a treatment for it, so remdesivir could be improved to the point where remdesivir works, or convalescent plasma, we could figure out a way to make that work, or we could have one of the immunoglobulin things. So I think there's a bunch of different strategies out there, and when I have to predict, I think all of them are possible, and we should go full speed ahead at all of them. So when we call this a moonshot, it's not really a moonshot, because with the moonshot, we knew exactly where we're going and how we would get there. In this case, what we're going for is we're attacking a bunch of different strategies all at once, and we may find that none work. That would be really disappointing. Or we may find that many work. So we may find we have 2 vaccines and 3 antivirals and 2 polyclonal antibodies that work. That would be the best of all worlds. I don't know how it's going to end, but I think no one thinks that we'll have any of those things before Christmas. And before Christmas means that we're likely now to have at least this second wave and maybe a third wave before we get there. I'll leave you with the good news again. Douglas County, no new cases this week, yay. And 27 have recovered. Still a sick guy in Portland that we're worried about, although we understand he's doing better. And we think overall people are doing well. And again, I have to thank people. People have been incredibly kind to the people who work in public health. You know, we have to contact people and say, look, here's bad news, you were exposed and you got to be quarantined. And the people's good humor about that and their willingness to cooperate has been truly touching. So there's one young woman I know who was in quarantine for 2 weeks, and her spirit about this was really quite great. And so I have to thank everybody for being so kind and so generous. And I think we're doing great. Again, this is Dr. Bob Dannenhoffer. It's time to go, and I'll see you again next Monday. Thanks.